So I'm just going to start with an introduction of what medications are approved for the treatment of Alzheimer's disease. You can see the first 4 drugs on this list are all what we call cholinesterase inhibitors. The one that we probably use the most is donepezil or Aricept, that has been the longest around, that's still around because Tacron is no longer on the market. And then memantine works differently on a different chemical in the brain. All of these drugs have a benefit for symptoms in terms of modest improvement in symptoms, and then they kind of tend to wear off. They give you a boost and they wear off. They don't really change the trajectory of the disease. And for a long time, I mean, that was what we had. And then in 2021, we had a newcomer on the scene, Lecanemab, that's been quite controversial. We'll talk about it. And then Lecanemab just now in January of 2023. Both these last drugs received accelerated approval from the FDA, not full traditional approval, and we'll talk about what the difference is in terms of can they actually be used clinically. And we'll talk about what happened in between in those 20 years or so to get to this point. So in the past couple decades, we have been focusing mostly in clinical trials on targeting the underlying pathology of Alzheimer's disease, primarily amyloid, but we have started looking at tau, which is the other main pathology of Alzheimer's disease. We've also continued to look for symptomatic approaches focused on cognitive symptoms and neuropsychiatric symptoms. And occasionally we've looked at more novel mechanisms or different mechanisms, focusing on neuroprotection and anti-inflammation and antioxidant targets. And so a couple symptomatic trials that I wanted to bring to your attention. So in the past couple of years, so pimavanserin is an antipsychotic, and unfortunately, as we know, patients who have dementia due to Alzheimer's disease and other conditions do have psychotic symptoms such as hallucinations or delusions, and also often have associated agitation, sometimes have isolated agitation. And so this particular drug was tested for the treatment of agitation and dementia and did show a benefit. It is being reviewed by the FDA for that indication potentially. It did previously receive an indication from the FDA for treatment of psychosis in patients who have Parkinson's disease, who can develop, aside from cognitive decline, also hallucinations, pretty vivid hallucinations, visual hallucinations. The next drug is this drug developed by Green Valley, a company based out of China, that is a substance derived from algae, and was tested in people with mild to moderate dementia, and showed a modest benefit for their overall cognition, but not any benefit for their daily functioning. So in China, they received conditional approval from their equivalent of the FDA, but this is not something that the FDA would approve here, because for this stage of disease, we want to see that there's a benefit for daily functioning as well. And so a trial was started in the US a little bit after the pandemic started, but basically got derailed by the pandemic and has now been restarted since then. So we'll see what happens with that. So these are just a couple examples of symptomatic trials. Then I want to talk about tau. So we know that the tau protein is important in Alzheimer's disease because normally it's important for the scaffolding of the nerve cells and transport of nutrients. But in Alzheimer's disease, it becomes abnormal and then, literally messes with that mechanism. And so it leads to neurodegeneration and death of the nerve cells in the brain. And so, researchers have tried to find ways to target this to help with treatment of Alzheimer's disease. And so a few years ago, there are several trials that were started with antibodies or passive immunization against the abnormal form of tau. And we participated in 4 of these trials at CART, at the Center for Alzheimer's Research and Treatment, and our colleagues at MGH ACTRU under Dr. Arnold also participated in one of these trials. Unfortunately, none of them really worked. One of them had a small signal of potential benefit, the Laureate trial that was in the more impaired participants, with some benefit in overall cognition, but not in daily functioning, like that symptomatic treatment I just mentioned. And so, so this first round was not successful, and more, is in the making. And so, this is an example of something that's coming down the road, targeting tau. The Celia trial is looking at a different way to attack abnormal tau in the brain to be able to reduce the formation of abnormal tau in the brain. And so we're going to participate in this trial, hopefully later this spring. It was launched internationally already in the summer. We're looking for people with mild cognitive impairment or mild dementia. This is going to be a different type of trial for us because, in fact, the drug is given into the spinal fluid. So if you're familiar with what, for example, anesthesiologists do, a spinal block where they introduce anesthetics into the spinal fluid. So it's the same type of approach. And in fact, we're partnering with an anesthesiologist because as neurologists, the primary physicians in our team, we remove fluid from the spinal fluid. We don't introduce anything in there. And so we're partnering with an experienced anesthesiologist who does clinical trials to help us with this. And so, so a different approach, and we'll see what happens with this trial. I want to shift back to talking about the couple recent drugs that were received accelerated approval, and we'll start with Lecanemab. So a lot of controversy about this. You've probably heard all sorts of stuff already, and I've seen some of these slides probably, and even more. So the drug was tested in two large clinical trials. Over 1,500 participants in each one, placebo versus two different doses. And the bottom line is that one trial, the EMERGE trial, that was primarily in Europe, showed a modest benefit of slowing of cognitive decline over 18 months with the high dose. But the other trial that was in the US, ENGAGE, did not replicate those results, and these trials happened at the same time. And neither trial showed a benefit with the low dose. And so, and then biologically, both trials at both doses showed that there was robust removal of amyloid from the brain. So this is an antibody against amyloid, trying to remove amyloid from the brain. And so it's biologically very active, but the clinical benefit was questionable. And then to add to that, we've probably all heard now about these side effects, amyloid-related imaging abnormality, or ARIA. Comes in two varieties. ARIA-E is an edema or swelling in the brain, or ARIA-H is an hemorrhage, in this case microhemorrhages, or tiny areas of bleeding in the brain. And unfortunately, the swelling reaction was quite high, frequent in people on the high dose. About a third of participants had it. Most were asymptomatic, but still a quarter of them had symptoms, and rarely they had significant symptoms. And so not a drug that's simple in that sense to administer, because you have to infuse it monthly and you have to monitor for these reactions. And so so despite the accelerated approval from the FDA early on, after a lot of deliberations, Medicare decided that they're not going to cover this drug outside of a clinical trial until there's more evidence of the clinical benefit. And so so there's going to be a third trial to kind of break the tie, which was launched this summer, the Envision trial. And we're participating in this trial as well. We're just starting this month to enroll participants, and this time will be, again, 1,500 participants, but it will just be one dose, the high dose from the prior trials versus a placebo. And in fact, there'll be a 2-to-1 chance to get the drug, so more people will be on drug than placebo. And so we'll see. It'll take probably about 4 years to get these results, and we'll see if, in fact, there is evidence of benefit with this drug clinically. Another drug in this class, Lecanemab, underwent a phase 2 trial. This is the Trailblazer trial. this one also removes amyloid from the brain, showed modest clinical benefit over 18 months. This was a phase 2 trial, so much smaller, 230 or so participants, but across the different clinical assessments, there was a consistent modest benefit. And there was a very robust removal of amyloid, even stronger than you saw with aducanumab. And basically, by the end of the 18 months, 2/3 of the participants didn't really have any amyloid in their brain anymore, at least not any noticeable specific amount. And so with this, they went ahead and did a phase 3 trial, which we're part of, the Trailblazer 2 trial, and it's almost done. Will be completed this April, and we're hoping to get the results in July. They also tried to get accelerated approval from the FDA based on their phase 2 results, but did not receive it. But hopefully the phase 3 results will replicate the phase 2 results and will then give more justification for approval from the FDA. Another drug in this class, gantenerumab, unfortunately did not succeed in the 2 large phase 3 trials that were reported in November. We participated in one of these trials, the graduate trials, and it didn't really show any clinical benefit, and the amount of amyloid that was removed was less than we expected based on the prior trials, and so that was disappointing, and it was a similar drug. So we were disappointed to see that, but they came out with the results quickly to let us know and stopped the development, unfortunately, of that drug. So then came lecanemab, which again, there's a theme here. So another anti-amyloid antibody, which had a phase 2b trial, large phase 2 trial with over 800 participants, where they tested 5 different doses to try and find out, which dose may be effective and move on to a phase 3 trial. And basically what they saw was that with the highest dose, there was a modest clinical benefit over 18 months. Again, kind of similar pattern you're hearing here. And with the 2 highest doses, there was a robust removal of amyloid. So basically came up with the potential of either 1 or 2 doses to look at based on the biological activity as well as the clinical benefit. And they did go ahead also and requested accelerated approval from the FDA and did receive it. Of course, when they requested this, it was when it was finally reviewed by the FDA, it was after their phase 3 trial results, which were positive, came in. The FDA did not review those results, but obviously were not blinded to it. So probably was an easier decision to say, we're going to grant this accelerated approval. Still not covered by insurance under Medicare, but we'll discuss the next steps here, which they're pushing for full approval. So the Clarity AD trial was the phase 3 trial with lecanemab. Same drug, similar population of mild cognitive impairment or mild dementia, 1,800 participants, so quite large for a single trial, and basically 1 dose versus placebo. So, many participants for each group, about 900, people had to have elevated amyloid in their brain. So very similar to what you've seen with these other trials, but a large single trial. And these are, the results. So on the left, we have the clinical efficacy results. So basically, again, this theme of modest slowing of cognitive decline and decline in daily functioning, consistent across all the different measures, and very robust removal of amyloid from the brain over 18 months. Also, when looking at protein in the spinal fluid and the blood, also a robust reduction of the abnormal form of tau. Very active biologically, and the clinical benefit that's modest. And then safety-wise, so the most common reaction was an infusion reaction. So about a quarter of participants had that. It's usually mild to moderate, easily handled by either slowing the infusion rate of the drug or by pre-medicating with things like Benadryl or antacids before the next infusion. In terms of the ARIA, the swelling, so 12.6% rate, so lower than aducanumab, but still not that low. and more common in people who have the gene ApoE4. And then the H piece, the microhemorrhages. So if they co-occurred with ARIA with the edema often, and if you remove it from that without the co-occurrence with edema, they occurred about the same rate as placebo. So it didn't seem like there's more incidence of microhemorrhages or tiny areas of bleeding unless they occurred together with the swelling. So what are the implications of the Clarity AD results? There was this accelerated approval based on the phase 2b results as mentioned, and there's still no coverage from Medicare or CMS. They're going to cover in a clinical trial only, and of course it's very expensive. So this is the current price tag, $26,500 for infusions for a year. But immediately after this accelerated approval, they requested full approval, and the FDA will make a decision by July. And Medicare has already said that they will cover it if the FDA gives a full approval, and they will just require a registry where, basically we collect some information about patients receiving the drug, but it doesn't have to be a clinical trial. So arguably, we're not ready for a drug like this. We don't necessarily have the resources to, do all the infusions for everybody. We don't necessarily have enough specialists who know how to screen people to see if they're appropriate to get this drug, and then to monitor them, looking for these reactions of swelling in the brain. And so there's a lot of readiness work that's going on now, and we'll need to get our act together quickly, because there may be many patients who are eligible for this treatment, and we're not necessarily ready to implement that. And then of course also the other piece is, you heard modest clinical benefit has been the theme here in terms of the response, and so. Is it the best thing to go with now? I mean, as opposed to, do we need more information? Do we need to see if we combine this with other treatments will have more benefit? And so those are important questions. So future directions. Also, another common theme is all these drugs are infused through IV, and so that's challenging. And so this particular drug, Lecanemab, they're also trying to test it as a subcutaneous injection, so similar to what you do with insulin shots that you can administer yourself. That would be obviously much more practical than getting an infusion, in this case, every 2 weeks. Other drugs in this class, like Lecanemab, we're anticipating results soon, like mentioned. Combination therapy with, if we have an effective drug against tau, maybe combining it with lifestyle modifications, maybe more aggressive control of cardiovascular risk factors. And then, of course, moving earlier in the disease process. These, I did not update this slide, I apologize. So the A4 results, which we did receive last week, which I do have a slide with those results, as a prevention trial, the AHEAD trial that's ongoing, and so we'll discuss those in a moment. So the AHEAD trial uses Lecanemab also, so this drug, and is two trials in one, looking for 1,400 participants. One trial or arm is looking for people with elevated amyloid in their brain who are cognitively normal, and the other one for individuals with intermediate amount of amyloid in their brain. And recently we incorporated screening with blood tests for amyloid, so not everybody has to undergo the PET scan. About 2/3 of people will be found to be ineligible based on the blood test, so they won't have to undergo the PET scan. And then we also have participants who go as young as 55, depending on various risk factors for Alzheimer's disease. The trial is 4 years long, and using Lecanemab, as mentioned before, and some novel PET scans. And it was launched 2.5 years ago now, and hopefully in the next year or so we'll finish enrollment, and we're participating in a CART. And so let's talk about the A4 trial, which was really the first prevention trial of this sort, looking at individuals at risk for Alzheimer's disease with elevated amyloid in their brain. I know a lot of the participants are actually on the call from our Brigham site. And so over 1,100 participants internationally were in this trial. 4.5-year long period of a trial of drug versus placebo, and then there was an extension where everybody got the drug. After that, the drug solanezumab targeted building blocks of amyloid in the brain, so different form of amyloid than some of these other drugs that we talked about that are more deposited amyloid closer to the plaque form. And the primary outcome was a cognitive measure, and there was a companion study that was called the LEARN study for people who had low amyloid in their brain who didn't get into the drug trial, and they were followed with the same assessments but without the intervention. And it was completed, the first part was completed in December, and unfortunately last week we heard the results that showed no clinical benefit of the drug. So basically solanezumab did not slow the progression of cognitive decline over 4.5 years. And there were various clinical assessments that were done, and they were all consistent and did not show a benefit. It was very much the same as being on the placebo. And then biomarker outcomes, primarily what we got so far is the amyloid PET scan that was measured, and there was no clearance of amyloid. Basically, both the placebo arm and the drug arm, they both accumulated a little bit more amyloid over the 4.5 years, so did not slow that process down, or unlike these other drugs that you heard. What was also seen is that about 1/3 of the participants progressed to a stage between normal aging and mild dementia. So one of our ratings, the clinical dementia ratings scale, basically we saw that there was progression on that over 4.5 years for about 1/3 of individuals. It got worse. And we also saw that the higher the amyloid you had at baseline, the greater chance you had of declining. From a safety perspective, it was very well tolerated. There were very few cases of swelling in the brain, less than 1%. So it was well tolerated, but unfortunately not effective. So that said, very disappointing results, but a lot of information has and will continue to come out of this trial. It was designed in a way to be able to answer a lot of questions. Of course, we wanted one important question to be answered positively, that it's effective, but it has and will continue to inform the design of future trials, which hopefully will not take us a decade, though, to get back to you with results, because this is almost a decade of work in terms of when this was launched, and a couple of years before it was launched, of additional work by the researchers. And so that is really not acceptable in terms of how long we take to find out the results of something this important. And so, and that is something that I think we learned and will, implement in future trials as well, as how to get answers faster. So a couple other prevention trials to talk about. So a couple of them are older here, ginkgo biloba trials. Just to put this out there that, every now and then we look at supplements as well. And it's important to look at them to see if they're effective, because unfortunately they're not under the, oversight of the FDA. And so they're, we don't really have necessarily evidence for efficacy or safety. And so the first two trials were done with ginkgo biloba that were prevention trials in primarily normal individuals, which unfortunately didn't show a benefit over the period of 5 to 6 years with several thousand participants. The next trial is pretty recent, was the Cosmos Mind trial that focused on two different interventions, either cocoa extract or multivitamin. And this was actually the Centrum Silver multivitamin, so they picked a commonly used multivitamin. And interestingly, the multivitamin showed a modest benefit. So it was modestly effective, and people on the multivitamin did a little bit better than people on the placebo or cocoa extract. And so that was nice to see. It was a very simple thing to do, take a multivitamin once a day. And so there's that. The next few slides, and I'll try and move quickly, is just to give you a little bit of an idea of what else we have going on at Brigham and Mass General for studies. And so the NMN trial is a small study that we're doing only at Brigham in collaboration with Shali Bassin, who's an endocrinologist, geriatric endocrinologist here at Brigham. And we're looking at this naturally occurring substance that tries to promote NAD, again, naturally found in the body, which we think has also a bunch of anti-aging and anti-Alzheimer's properties. And it's given as a pill. We're just trying to first show that it interacts with the brain the way we want it to. And so we're going to measure this substance in the brain with an MRI as well with spinal fluid. And so we're looking for, only 24 participants who have mild Alzheimer's disease dementia. Next trial, called the STAR trial, is looking at also a pill, an oral medication, but affecting amyloid again, but a different mechanism for trying to reduce amyloid, and is for people with either mild cognitive impairment or mild dementia. And we'll hopefully start early summer. We're still going through the paperwork and logistics for that. Then there are several trials that our colleagues at MGH under Dr. Arnold at the ACTRU are doing. So the first one, the J&J trial, is an antibody against tau, so a next generation antibody. So hopefully we'll have better success than the first generation, those three that we looked at. And so that one is looking for participants, again, with kind of early symptoms of Alzheimer's disease. The next three trials, starting with the Novartis trial here, are looking at agents that affect inflammation, so trying to reduce inflammation in the brain. And so there's that trial and the BCG vaccine, which, if that sounds familiar, it is the vaccine that we use to inoculate people against tuberculosis. And there is, in fact, evidence that it could reduce inflammation in the brain from the lab setting. And so so Dr. Arnold's team is trying to see if that could be helpful with early cases of Alzheimer's. And then again, the NADL study, again, so targeting inflammation. So these are different, more novel mechanisms that are being looked at. And then the last couple slides are talking about some of our observational imaging studies. Non-intervention, and these are studies that are happening at MGH, at the Charlestown Navy Yard. So the first one is focused on people with subjective cognitive decline. So they test normally, but they notice that something is off and they report it. And so not meeting criteria for mild cognitive impairment. So somewhere in between their normal aging and mild cognitive impairment. And they will be followed over 4 years with a bunch of clinical assessments and scans of their brain. The next one, the IDL study, is looking for, at this point we have almost all of our cognitively normal participants, but also looking combined with the subjective cognitive decline group, and we're looking for people with mild cognitive impairment. We have a bunch of different computerized and smartphone app tests and questionnaires, as well as the same imaging that you saw before. And this apathy study is looking for people with mild behavioral impairment, so kind of an equivalent of mild cognitive impairment, but more symptoms of behavior, apathy, depression, irritability, anxiety, and looking at scans of their brain. The AWARE study is looking for people with mild to moderate dementia and is focused on awareness or lack thereof of their cognitive deficits and trying to see where does that live in the brain with different scans of the brain. And all these studies are pooling their data. And so we're doing some overlapping assessments in order to be able to answer these questions across different stages of disease. And then finally, the SONNET study that's focused on sleep as one of its main foci, where we actually go to participants' homes and do sleep studies on them, as well as actigraphy, a variety of other measures of function and scans of the brain. So this is just to give you a little sampling, and we can provide this information later, but just to give you a little sampling of studies that are ongoing. And so certainly if there's interest in participating, you can see there's a wide variety of either imaging studies or clinical trials that we're doing across Brigham and Mass General. And I think that is the end of my slides. So I will stop. Sorry for rambling on and on, but hopefully now we can hear from Joe Costello, one of our wonderful research participants and ambassadors. Thank you.
Thank you, Gad. Happy St. Patty's Day to everybody. In case you're worried, this is not Irish coffee. Plain old Starbucks decaf. And this is my research hero mug, which I very much appreciate having received from Brigham and Women's. And you can tell it's so loved that all the printing is now worn off it, but it's still functional. Maybe there's a message there. Let me put up my slides. For about 9 years, I was a subject in clinical.
Joe, we don't have your slides up.
You're not seeing the slides. Oh, well, let's just.
Okay, perfect.
You're seeing them now. Okay. I was a subject in clinical research into the prevention or postponement of Alzheimer's. Over this time, I've received 104 infusions to evaluate the Alzheimer's drug that Dr. Marshall had just spoken about called Lecanemab. And that study is just now wound up. And as you know from Dr. Marshall's report, the conclusion about Lecanemab was negative. And I'll let you know a little bit later about how that's affected me. My purpose over the next few minutes is to share what's happened with me in this research. I'll explain what I was looking for when I got involved, my experience with the study, and some thoughts as I look back over these 9 years and forward now that the study has been completed. I'll concentrate especially on things that might be of interest to people that are considering research participation. When I entered the A4 study, I was just about to turn 70 and felt pretty healthy. I was and continue to be actively involved in my organizational consulting practice. I felt then and still do that I have a lot more yet to be done professionally. So I was worrying about how my brain might hold up. In December of 2013, I heard a report on WGBH about a new research study. When I tracked it down, I learned that it was the brainchild of Dr. Risa Sperling, and I located a TED Talk that she had given the prior year. I was so bowled over by that, I was ready to take part in absolutely anything that she was leading. So I started reaching out to people at Brigham and Women's and ultimately connected with Alison Pietras. I was happily surprised to be able to reach the study principles so quickly. Through Dr. Sperling and Dr. Rentz, I ended up in conversation with Alison. After some initial discussion and cognitive testing in April 2014, I was summarily rejected as a study subject. And then thanks to Alison's initiative, I was invited back in June after some A4 guidelines were reformulated. Getting started in the study required a partner, a bunch of forms, and 5 screening visits. The screening involved everything from family medical history to ECG, PET scan, and MRI, as well as cognitive tests. This elaborate 90-day-long process enabled the researchers to be sure that I wouldn't be taking any undue risks and that I was right for the study. Not long after I signed up for A4, the study began to morph into something a good deal larger. What had been a 400 milligram dose escalated to 1,600. The original 40 infusions increased to 66, and new optional tests were added. In a 2018 WBUR interview, Dr. Sperling said, "We quadrupled the dose," which is a gutsy thing to do in the middle of a trial. All this change prompted me to do some homework that I probably should have done before getting into A4. What I learned was incredibly impressive. The study plan or protocol that I found on the clinicaltrials.gov website was reassuringly detailed and was the product of a whole bunch of experts. The protocol was applied in minute detail to the consent form that had been explained to me by the Brigham and Women's staff, both initially and again each time it was updated, and it was signed by them as well as by me. The study involved both an institutional review board and a data and safety monitoring board, and I was being closely monitored personally. The monitoring process, which is detailed in the consent form, was carried out scrupulously. All the measurements that were being taken to generate study data also enabled the staff to spot any issues that I might develop. And in addition, every 4 weeks, right before my infusions, the research staff checked carefully into my personal situation and updated my records. This monitoring process constantly reinforced the feeling that I was in good hands. Looking back over my 9 years in A4, I think of the experience in 3 categories. It's unquestionably worthwhile to do something, even something as small as being just one of 1,100 A4 subjects, to address a problem with the scale of Alzheimer's. Unless folks are willing to try new medications, there will be no new medications. And I feel good about knowing and being able to pass along to others information about Alzheimer's that I would not have known without being in the study. For me personally, having completed my 66 double-blinded infusions in November 2019, I am assured of having received at least 40 doses during the open label study phase of what was, in 2014, the best option for Alzheimer's prevention. Taking part in the study really didn't interfere with my work, and I've been able to replace worrying about my brain with the feeling that I'm actually doing something positive about it. The only downside from being in such a long study is that while I was taking part in A4, I saw other Alzheimer's drug trials fail, which was worrisome. And now new drugs have come along and are being touted by their manufacturers as the new state of the art. But we always knew that the ultimate test of solanezumab would be the A4 outcome, and we persisted in our optimism. What may be most gratifying from the A4 experience is coming to feel at least a small part of the Alzheimer's research community. Meeting with the researchers and with the other research participants, and especially taking part in the Research Ambassadors program, have added an important new dimension to my life. Through the annual recognition meetings we had before COVID, our monthly CART group sessions that are now on Zoom, education and update meetings hosted by Alzheimer's experts like Dr. Marshall, and regular appreciation coming from the research staff, I have constantly felt that I was getting way more than I was giving. So now it's 9 days past the announcement that solanezumab did not achieve the biological and cognitive results that we'd all hoped for. When I heard on March 8th about the A4 results, I thought, kind of like Dickens, it's the worst of news, the best of news. Before I explain this, let me give a bit of context. As a research participant, my viewpoint is very different from the researchers who have invested so much of themselves to create an important contribution to brain health. They are justifiably disappointed. And I bet it's harder for them to see a silver lining in this. Second, my objective as a participant was to keep something bad from happening to me. And 9 years later, still nothing bad has happened. And a third caveat, I am just one person out of 1,169 in the A4 study and way more in all clinical trials. So my personal reaction to A4 shouldn't be overgeneralized. With no pretense at humility, as the analysts say, I am not statistically significant. But with all that caveating, here are my good news and bad news. The very authoritative report that I got from Dr. Marshall just a couple of weeks ago is that my cognitive status is still consistent with what it was when I joined A4 in 2014. In a sense, I'm kind of flatlining. This is as good as I could have hoped for when I joined up with A4. Had I not been part of the study, I would not have had encouraging reporting about my cognitive health every 6 months or so. I used to kid the CEO I worked for that I was the only executive on his team whose mental health was constantly being monitored and certified. Some of his other executives I don't think would have passed. So to me, the study outcome is that I'm certified okay, more or less, don't want to exaggerate, and that my mental acuity is not dependent upon a drug. All good, right? But I certainly felt a bad news gut wrench when I saw the A4 headline. And I think this is why. 9 years ago, I signed up to take a risk from which the benefit was potentially being an early recipient of something like a miracle cure. Certainly not the way it was ever described by the researchers, but then we all write our own narratives. Now I have to admit to myself and others, I made a bad call. That'll keep me humble. But for me, the balance tips, nevertheless, heavily in the direction of a positive outcome. For me personally, for the chance to make a worthwhile contribution to dementia research, and for a great experience with everyone at Brigham and Women's and in the A4 study group. My reaction overall is so positive, in fact, that I'm already working on getting myself into another Alzheimer's prevention clinical study. As I wind up here, I want to remind you that the madrick.org website contains, among other things, great information about dementia research studies and how to connect with them. Keep in mind that for those who'd like to become part of the research effort, but are not inclined to receive an experimental drug, there are numerous observational studies. And then there are clinical studies, ones like Dr. Marshall mentioned, that will ultimately enable the research community to bring greatly needed new medications to people with dementia, and perhaps even to those like me with markers, but no abnormal cognitive decline. For your personal follow-up on anything we've discussed, here's Nancy Koppelman's email address. Now, Dr. Marshall will answer your questions, and I'll be glad to weigh in if you have any for me. Thanks, Nancy, and thank you, Dr. Marshall. A deep, sincere thank you.
Thanks very much, Joe.